Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so glad you could join us today for our special edition. Today's program is all about the eye. We've had two experts talk about the eyeball. Dr. Eric Del Piero discussed the retina. Dr. Leland Rosenblum discussed cataracts. And it's my job as a plastic surgeon to talk about the eyelid and eyelid surgery. Eyelid surgery is one of the most common requests that I see in my office as a plastic surgeon in my practice here in Monterey. Eyelid surgery can be very rewarding. It's meticulous surgery. It's one of the most common procedures that we do in plastic surgery, as I mentioned, and it can lead to a high percentage of satisfied patients. First of all, let's talk about the type of conditions I see in my office as a plastic surgeon related to the eyelid. Oftentimes people will come in and say that their eyelids look tired or their eyes look tired, but they're not tired and they want to do something surgically about it. They'll oftentimes show me that they have lots of extra skin on the upper lid. Oftentimes, sometimes mistakenly, they'll say, look at all the skin on my lower lid and what can we do about these skin pouches? But in general, people like their eyelids and the eye or the periorbita, what we call the eye region, the periorbita, to look as good as they feel. Now to begin, whenever I do an eyelid evaluation, we need to look at the adjacent structures, and that's vital. The adjacent structures to the eyelids are of course above the eyebrows and of course below the cheeks. Let's start with the eyebrows that are above the upper lids. There's something called eyebrow ptosis, where the eyebrows themselves will descend or drop. And that makes, it almost leads to an optical illusion, if you will. It leads to an illusion that there's lots of extra eyelid skin, when in fact, there's not necessarily all that much eyelid skin, but the brows themselves have descended and come down, leading to an illusion that there's lots of eyelid skin. So of course, not everyone is eligible or even willing or wanting or needing eyebrow lifting or eyebrow surgery, but certainly as part of the evaluation of the periorbita or the eyeball region, eyelid region, we have to look at the position of the brows and certainly the forehead. In cases of eyebrow ptosis, where the eyebrow has descended significantly, there are many different ways that we can lift the brows. There's something called a direct brow lift. In patients with deep forehead lines, we can pick out one of the lines and actually make an incision within one of the deep furrows. We can change a furrow into a scar, and in many months, or in some months, it's very difficult to see in most cases. We can make very small incisions in the scalp and use something called an endoscope to do an endoscopic brow lift. We can make limited incisions in the temples and sometimes in the top portion of the skull or scalp, and we can slide in instruments and manipulate the eyebrows. And of course, there's the traditional coronal brow lift, where we make a long incision in the scalp and thereby slide down and manipulate the muscles in the forehead and in the glabella. That's the area between the eyebrows at the top of the nose, and of course the eyebrow position themselves. So there's lots of different ways that we can manipulate the position of the eyebrows. As I said, through very small incisions in the scalp sometimes, or through longer incisions. Everyone gets a custom designed approach. Now, I did mention the glabella. That's the area in between the eyebrows where people can sometimes get furrows, and the people who make the Botox refer to that area as, of course, or they call those lines the 1s or the 11s or the 111s. Glabella furrows are very common. There's two muscles, the procerus and the corrugator muscles, that are responsible for making those furrows. And those furrows or lines can be softened by Botox injection. I do Botox a lot for that area, and it leads to a very high percentage of satisfied people. We cannot make those furrows disappear, but we can certainly soften them with Botox. And if someone wants even additional improvement, then a filler or fat can help. So we've talked about the brows, I mentioned the forehead briefly, and we've talked about the glabella. We do have to be very careful, especially in men, not to over-elevate the brow. And men, in our culture, a low, strong, sometimes horizontal brow is a sign of virility and strength, and it's a very masculine sign. if we over-elevate the brow, especially in men, it looks somewhat odd. For the ideal eyebrow position and shape in the female, it tends to gently slope upward to about 2/3 of the way to what we call the lateral canthus, or almost at the level of the corner of the eye. And then there's a gentle horizontal curvature or straightening, horizontal straightening, or even a slight depression. But certainly for the ideal female form of the eyebrow, it tends to slope upward for the medial 2/3. Or what I mean by the medial, the 2/3 of the brow closest to the nose. Okay, so what about the upper lids? It is true that sometimes people will lose resilience in their upper lids, and there's extra skin. That's fairly straightforward because the extra skin can be trimmed and tailored in a procedure called a blepharoplasty, or eyelid tuck, or eyelid trimming. A blepharoplasty can be very helpful, very efficient, and very good at removing and tailoring and trimming and sculpting the extra eyelid skin. There's also pseudoherniated fat. Now let's back up for a moment. Everyone's eyeball, or the globe, is cushioned and lubricated by fat. It's held in place by a membrane called the septum, the orbital septum. For some reason, in certain families, that septum starts to get weak and the fat starts to almost push through or protrude. It's not a true hernia, but it is what we call pseudoherniated fat. Those fat globules that cushion and lubricate the globe tend to push through and will oftentimes give someone a puffy eye appearance or tired eyes. So when I look at someone's upper lid, we need to look at the amount, or is there extra skin, and I look at the puffiness or fat globules. Now, typically I will address the compartment closest to the nose, that's called the medial compartment. I'll address the compartment just above the pupil, that's called the central compartment. The lateral compartment does have a little bit of fat and can be full. However, that lateral compartment contains the lacrimal gland, or the gland that is partly responsible for making tears. And in my practice, I do not like to manipulate or remove or even suspend that gland because the tears are so important. Now, before I go to the lower lid, I want to mention briefly a condition called ptosis, or more commonly called lazy eyelid syndrome. Ptosis of the upper lid is where the lid itself does not open fully to allow the full spectrum or full circumference of light to come into the pupil or into the eyeball. That's called true ptosis. It can be caused by a number of conditions. Babies can be born with this. People can develop something called a senile ptosis, whereby just simply with time and age, that muscle, the levator, can wear out or become weak or actually tear apart from the dorsal plate or become separated from it. Thereby the action of the levator muscle is ineffective or incomplete in lifting up the eyelid away from the pupil. That's called true ptosis. There's another kind of ptosis called lash ptosis, whereby there's so much extra skin that the eyelid itself, the eyelid skin itself, is actually resting upon the eyelashes. And it's the eyelashes that are keeping the eyelid skin from dropping down below the margin of the lid. Both of those conditions can lead to something called visual field obstruction, whereby the actual amount of light is diminished that's coming into the pupil. Again, that's visual field obstruction, and some of the most common causes of visual field obstruction are true ptosis or severe lash ptosis. Now let's go to the lower lid. The lower lid can be affected by many conditions. Primarily, I hear from patients coming into the office questioning or complaining the lower lid pouches. And oftentimes I'll hear patients say, can't you remove this extra skin, that it's the cause of these pouches? Well, it's not really a lot of extra skin. It's possible for the lower lid to get somewhat or limited amounts of extra skin, but to remove aggressive or a lot of extra skin from the lower lid can oftentimes lead to problems because it can actually lead to a shortage of lower lid skin. That condition is called ectropion, whereby the position of the lower lid is too far down towards the cheek, and it can lead to exposure of the globe itself, exposure of the sclera or the conjunctiva, and the eyeball can become inflamed. Again, that's called ectropion. The lower lid serves as a kind of dam to keep the tears in the sulcus, the tears against the globe itself. And there's something called epiphora, whereby the tears can, or the tears that are designed to lubricate the eyeball actually drip down onto the cheek. That's called epiphora. And that can happen with a very lax lower lid or frank ectropion. But what about those lower lid pouches? That's primarily from pseudoherniated fat. There are 3 compartments in the lower lid, the medial, the central, and the lateral. They're all of those pouches are caused by the pseudoherniated fat that I talked about for the upper lid. The fat that surrounds the globe is held in place by the orbital septum. It's a very thin membrane. In some families, that septum becomes weak and the fat starts to protrude through, pushing against the skin and orbicularis muscle, orbicularis oculi muscle. And those are commonly seen as fat pouches, but we call that pseudoherniated fat. Next, we need to look at the muscle. That's the orbicularis oculi muscle. That can become lax. And sometimes the lower eyelid will sort of sit at a lower position than it needs to be, or that it should be, and the eyes can look somewhat tired, and people can have almost rings under their eyes. To correct that, we need to address each layer of the lower eyelid, and we'll sometimes do what's called a lateral canthoplasty or canthopexy. That's when we go in and the supporting tendon, the support ligament of the lateral canthus that supports the position of the lower lid to the orbit or the bone gets a little bit lax, and we actually shorten that or reposition it. That's called a canthoplasty or canthopexy. And so eyelid surgery, before we do any eyelid surgery, we need to actually look at each layer. We need to look at the skin. What's the texture of the skin? What's the quality of the skin? Is there extra skin? Is there a shortage of skin? Next, we look at the muscle, the orbicularis oculi muscle. Is the muscle lax? Is the muscle thickened? Is it hyperactive? Could it be helped by Botox, etc.? Then we look at the septum and the amount of pseudoherniated fat that's trying to push through. So we need to go layer by layer. Now, to operate on the lower lid, for the pouches, if someone has extra skin, even a slight amount of extra skin, I'll do what we commonly call the external approach or external pinch approach. That's where I make a very thin or very short, actually not always short, sometimes the entire length of the eyelid, but a thin incision just under the lashes so I can gain access to the extra skin. I can also gain access to the muscle if need be. Now, in those times when the person has extra skin and pseudoherniated fat, I can slip in and address the fat pouches through that approach as well. However, there's another approach where if someone does not need skin removed or need the external lamella or an external layers operated on, I can slip in to the inside of the lower lid, and that's called the transconjunctival approach. It's very effective. It's a good way to get to the lower eyelid pouches, and of course it leaves no extra scars or no additional scars on the skin, the outside of the lid. Now, I did say that we need to look at the associated structures when we look at when we're considering any eyelid surgery. I mentioned the eyebrow, forehead, and glabella before we address the eyelid skin. The cheek below the lower eyelid is the foundation of the lower eyelid. The cheek can actually pull down upon the lid just by having a cheek that's descending down, or what I call mid-face descent or malar descent. When the malar area or the cheekbone area, when the soft tissue is descending down and being pulled towards the neck, that can actually cause traction on the lower lid and make it look older and make it appear to be tired, even though it's not old or even though it's not lax. It's just that the traction of the cheek is pulling down upon the lower eyelid. So oftentimes we need to consider a procedure where we resuspend or lift the midface or malar area, that way improving the foundation for the lower lid. There's one other area that I want to address before we wrap up talking about the lower lid. That's what we call the tear trough. The tear trough is found next to the nose at the cheek eyelid junction. Of course, for the cheek and the eyelid junction, we desire for that to be smooth. That's a youthful appearance. When people get a sort of a deep groove towards the nose at the cheek eyelid junction, that's called the tear trough. And that will respond quite well to fillers or even a person's fat. Now, oftentimes I'm asked about dark circles under the eyes. That's very complicated. It's oftentimes a vasomotor problem or even hyperpigmentation in the skin. That's not typically treated by surgery. Oftentimes there can be sinus problems, there can be pigment changes, there can be skin conditions that we need to treat. But the primary treatment for dark circles under the eye really is not surgery. However, there are plenty of conditions we can treat with eyelid surgery, and it all starts with a careful custom analysis, and then that leads to a custom designed surgical approach. Thanks so very much for listening today. This is Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so glad you could join us today for this very special edition all about the eye. Thanks for being here. Your Health radio and television program. Once again, I'm Dr. David Morwood. Thanks very much for being here.